Time I have to wait for people who are late.
Okay, sir. Let me start, sir. Just.
I think you can start, sir.
Yes, sir. Sir, I am
Already,
starting, sir.
four of us are there.
Yes, sir. Yes, sir. So, sir, on behalf of Alchem Cardiology Division, I am Girish Jamnani, DSM Ahmedabad. I'd like to invite you and welcome you all delegates and our panelists and our definitely our moderator, Dr. Hemant Makad, to start the event today evening. Specifically, we are going to discuss on the views on vildagliptin. Our topic is views on vildagliptin, and for handling entire session, we have our moderator, Dr. Hemant Makad, with us, who is consultant diabetologist practicing in Ahmedabad in various hospitals like Sal Hospital and Medisurg Hospital, and for paneling this panel, entire panel, we do have our panelists. Dr. Shabbir Gadi from Ahmedabad, consultant physician and diabetologist, and Dr. Rajendra Shah from Surat, who is practicing at Surat as a consultant physician and diabetologist. Shortly, Dr. Nitesh Patel, diabetologist, and Dr. Jitendra Nagar is also supposed to join. But before that, I would like to request Dr. Hemant Makad to take the charge and start the panel discussion, sir. Sir.
Yeah, thanks, Girish.
Yes.
What we are going to keep it very simple.
Yes,
We are going to address um, the emphasis on the DPP4 inhibitors, number one. Number two, all the panelists who are large volume of practice will tell us what is their preference and why. And number three, in a new onset diabetes, what are the guidelines they follow about starting the therapy, um, metformin or dual therapy or single therapy, lifestyle alterations. Number four, with the advent, whatever we thought was the problem with vildagliptin as far as the compliance was concerned, but that was the only DPP4 which needed to be taken twice a day because of its shorter half-life. But that became an advantage because it controlled the fasting plasma glucose better and had lesser glycemic variability and with greater DPP4 inhibition to the tune of 94%. Um, I really wonder if I were Alchem, I would not even bother to get an OD preparation because my BID preparation was a great advantage where it took glycemic variability in control, had a better cardiovascular, hence outcomes. Number three, it controlled the fasting plasma glucose better than even sitagliptin. There is a head-to-head trial which said that. And finally, if for the compliance sake you have 100 milligram of OD preparation, I really wonder whether we have tweaked the technology to last it for at least 20, 22 hours, because that is what we plan to discuss. And of course, finally, with the cost um, plummeting because of the off patent of vildagliptin from the original innovators, Novartis, now being available for close to about 5 to 6 rupees a day. I think the greater acceptance because the cost will be there. And I'm very happy that um, a very weak agent like teneligliptin, which controlled only 53% of DPP4, hence was of no value because for any DPP4 inhibitor to be clinically significantly effective, it has to control 80% and above of DPP4 enzyme. Even if you gave 20 milligram of teneligliptin, it controlled close to 53%. And if you went to 40 milligram, it controlled only 62 to 63%, which was horribly inadequate. Since we have the situation where we have the cost of DPP-4 come down to close to about 5 to 6 rupees, and a very effective one at that. I think it's a big step forward as far as the prescriptions go, and acceptance and compliance, and hence the adherence from the patient's point of view goes. So I would like all the panelists, all the esteemed gentlemen, to share the views. What is their preference? How would they also view the efficacy, durability, safety, and then, of course, the special group of individuals like old age or cardiovascular or renally compromised individuals and their treatment as far as the vildagliptin goes. And of course, touch upon the EDGE and the verified trial and head-to-head data between vildagliptin and sitagliptin. So, Dr. Shabir, we may start since you joined early. You get the first roll of the dice in your favor. Please go ahead and share your views, sir.
Thank you, sir. It is a pleasure to talk tonight, and thanks for giving an opportunity, Girish Bhai and Makar sir. Sir, as you have already explained everything regarding vildagliptin, as you said that we people are using it, vast number of people these days vildagliptin, and what our experience is. I would say that metformin was is always remains the first choice of drug for any other diabetes. So if in a NEVI patient, if I start with metformin. But if I use second other drug, then obviously DPP-4 becomes a cornerstone in my treatment. The one thing which I prefer and everybody else also prefer is that we should preserve the beta cell. So as far as we can avoid sulfonylurea and we can control the diabetes, maybe either with DPP-4, metformin, and if the patient can afford, then SGLT2 inhibitors or GLP-1 analog can be also used. So along with all other drugs, I prefer to give vildagliptin. As sir, you already told that because it is given BID dosage, glycemic variability, as we are not aware that nowadays controlling glucose is not the only thing. We should control the glycemic variability as well, because the glucose should remain in time. So all the time the glucose should remain under control because of the drugs which are having not having a long half-life. So in between the blood sugar increases, and that leads to a deranged HbA1c or glycosylated hemoglobin. So that we are having all macro and micro complication because of the uncontrolled diabetes. So this as a drug can be given BID, which can control both the postprandial as well as fasting sugar. It is a very effective compared to teneligliptin, as sir you have already explained. So nothing more to say regarding teneligliptin and vildagliptin. I'm still skeptical using OD dose, but as there is a market, only after using it, I think time can tell us that whether how effective it would be and whether I should use OD or I should continue with BID dosage. That's all from my side, sir.
You know, Shabir, well said, very well said, because let the gentleman from the pharma company tell us about how long is the half-life of the OD preparation. Girish, can you come in, please?
Sir, as per bioequivalence study, what we have done specifically for vildagliptin OD dosage, as per study, sir, it is showing almost 5 hours half-life time, sir.
What? How many hours?
5 hours, sir. Actually, BID dosage vildagliptin is having half-life of 2 to 3 hours vildagliptin. And for OD dosage, it has been observed almost 5 hours, sir.
Huh. Okay. You know, Shabir is smiling. There must be a reason why he's smiling.
There should not be any reason to prescribe OD dosage. Then it should be BID that would be more better to prescribe.
I think there is a big problem here. I think you need to go back to the drawing board and find out, because, you know, when something is good, we all have this need to do better. The only enemy good has is better. Good is good enough. And twice a day, you guys made it once a day. Clinicians made it half a tablet to save money when Galvus was the only thing available. And that's how diabetes is being treated suboptimally. And we have sold our souls. I exempt myself. I never give Vildagliptin OD. Hence, I have huge reservations about your OD preparation. You may not like to hear this, but this is how I talk. So, unless I give it twice a day, unless I cover almost 20 hours or 22 hours of glucose level, and in fact, your greatest advantage, which you thought was your weakness, was controlling the fasting plasma glucose better than, as Shabir rightly put, the glycemic variability
That's
was
it.
actually much lesser because you had a longer, if you compare to sitagliptin actually started huffing and puffing at 16, 18 hours, and you lost control after midnight if you took it in the morning. And that's the advantage you had. But then you tried to get cuter and got the OD preparation. Fine, good enough. So if you have greater data, and hence the acceptance levels of OD is going to be a problem. The second thing, Shabir, is
Yes, sir.
you said metformin remains the gold standard. I'm nobody. I'm absolutely nobody to. But when do you actually start thinking that only because the greatest or most effective anti-hyperglycemic thing is lifestyle alteration, which is weight reduction, exercise, and diet with low glycemic indices food. Nothing, not even insulin comes closer. It has a massive effect. We have various studies, and then we go on to giving metformin. When do you actually give dual therapy?
So practically,
New
if you think
onset.
that whatever the lifestyle modification that would be advised to every other patient, but the acceptance in the practically they are taking in their life is very, 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 very small percentage. Whatever you advise, they are not going to follow it out, and very few number of, I say, very small percentage of people literally follow our advice in lifestyle modification and dietary advices, right? So the if at all whatever OHA we give to the patient or insulin we give to the patient, if it increases the sensitivity, because truly speaking, sir, I'm very good fan of pioglitazone more than any other drug, because Indian market, if you compare the cost and if you see the obesity among the people, population having diabetes, it works wonderfully. So for me, pioglitazone and metformin remains a major cornerstone in my treatment. And as it decreases the hepatic output of glucose. Although people who are having above 6, below 6.4 HbA, which is still I start them with metformin, because at least they will have some fluctuations, they will take some lesser food. So I advise them that this will decrease your body weight. Maybe the metformin is directly not decreasing the body weight, but because of the fluctuations, they are able to take a little lesser amount of food. At least that will give some decrease in the carb or the energy, and that's where we can reduce the weight.
In which
Maybe it is not a right thing
subset?
to say, but this is how you.
No. In which subsets would you start without batting an eyelid a dual therapy? It could be anything. It could be SGLT2 metformin. It could be DPP4 metformin. It could be
If
pioglitazone
if the
metformin.
patient is obese, if the patient is obese, then without thinking, if the patient can afford it, I'll give the best SGLT2 inhibitor, because the moment they reduce their weight, the diabetes comes under control and we can prevent so many complications. So SGLT2, I'll prefer to give every other patient. Even before prescribing DPP4 inhibitor in our patient, if you prescribe SGLT2, that is a boon for the patient. And as the SGLT2 is coming with a cheaper rate these days, I'll prefer to use this.
Yeah, there are guidelines, of course. Let Rajendra and everybody else come in, which tell us, and AACE has more stringent guidelines by telling us that the moment in a newly diagnosed type 2 diabetes, you find right at the beginning for that particular cohort, that particular patient who is newly diagnosed, young, motivated, without any macrovascular complication, absolutely virgin field to play around with. I guess if the target HbA1c is 6 or 6.5, and the moment the HbA1c is 1.5% higher than what that should be, then we must start with dual therapy. The Rajendra, what is your opinion?
Yeah, I agree with you, sir. In fact, what I want to say is that even before the Vildagliptin was available from other companies, means when it was available as a Galvus only, even that time we used to write this lot, and we have been writing In fact, it has been a boon for us when this vildagliptin is available now. It is patent-free and is available at cheaper price. Specifically, it has got certain advantages over other gliptins also. And in fact, I prefer all the patients who have got who are a normal weight or obese with HbA1c more than 7 or 7.5 patients. I would prefer to start first as a vildagliptin.
Okay. Anybody else until we rejoin Rajendra? Girish?
Ji sir. Sir, Dr. Nitesh Patel has also joined, if you allow.
Yeah, so Mitesh could pitch in with his wisdom, please. Mitesh?
Yeah.
Nitesh, sir.
Hello?
Yes, sir. Yeah.
Yeah, so we were discussing actually, and before Rajendra went off air, you know, the advantage of dual therapies, specifically metformin and DPP4. And here I have a couple of very important scientific data, which is proven that we Asians, especially Indians,
Yeah.
compared to Caucasians, have a very high circulating DPP4 in our tissues, enzymes.
Mm-hmm.
The efficacy, hence, of DPP4 inhibitors is always greater in Indians, while we were told that it only lowers 0.6 or 0.7, which is equivalent across the board for all DPP4. Let's presume that for theory's sake. In Indians, it was observed it could sometime go up to, of course, depending on the HbA1c levels you started. But even when you started at not a very high HbA1c levels, because of the very high circulating DPP4 enzymes in us, the DPP4 inhibitors work better and at a greater lowering of HbA1c compared to Caucasians. That's number one. And number two, of course, the synergistic action of metformin
And
with DPP4 enzymes on the GLPs and GIPs. Not so much the GIP, but the GLP, where there is a synergistic action. It augments the level and then it makes a fertile field for the DPP4 to inhibit the GLP. So on both counts, I think, but my question is the fear that we have. If you have, Mitesh, really compromised individuals, if you have to choose a DPP4, does the mind go because of whatever we have been taught about no reduction required in linagliptin, only gliptin that we write, or what do you do in your practice?
Yes, sir. That's a fantastic question. And let me tell you the era somewhere around 2015 when the linagliptin came into the market. At that time, the people, BI, what they are telling a story, and they move forward with the same sentence that you can prescribe in any failure. It may be renal failure or it may be hepatic failure. And because of that reason, in that era, we used to prescribe linagliptin. But as we understand the basic pathophysiology and basic concepts of pharmacokinetics of DPP4 inhibitors, we used to prescribe all gliptins, but that depends upon the basic EGFR value. If you have EGFR more than 50, you can prescribe safely any gliptin at full dose. Between 25 to 50 EGFR, we have to half the dose, particularly vildagliptin and these two. And if EGFR beyond 25, below 25, and we have to again cut down further the dose, and we have to use, in fact, we are using vildagliptin. But for me, whenever patient with altered kidney function test, altered reduced EGFR value, we used to prescribe linagliptin a lot. We used to prescribe tenaligliptin as well. I used to prescribe sitagliptin and vildagliptin, but in a limited sets of patients.
Okay.
Those who are already on this sita or vilda, and if they came with the reduced EGFR value, then we adjust the dose and we prescribe same gliptin.
Okay. What about transaminases? Would it be a problem for vildagliptin?
Yeah, sir. In fact, nowadays, after this off patency of this vildagliptin, we are prescribing a lot vildagliptin. But before that, it was a subconscious question in my mind every time, because I have seen one patient with altered hepatitis with this vildagliptin, and because of that reason, we used to be cautious before prescribing this vildagliptin. That is not the case with other gliptins, but that was the only single case I had seen in my last 10 years. So looking at this 10 years, my practice, in fact, since last almost 1 to 1.5 years, we have prescribed more than thousands of vildagliptin, and we have any case of hepatitis or any change in transaminases. And in fact,
Rajendra, how frequently do you
there
get
are
the
examples.
liver function test done when the patient is on vildagliptin?
No, sir, that's why I'm telling you there are certain examples as well. Those who have borderline liver function test transaminases, and we have done that transaminases on borderline. We have prescribed vildagliptin, and that the patient remains stable without any complications.
When you start thinking about you might have to change the gliptin, at what level of transaminase? Because the alarm bells would ring where you would feel that. So is there a cutoff point in, let's take the SGPT?
At least 1.5 to 2 times of upper normal limit. In fact,
Okay.
I would not like to utilize vildagliptin, but if it
Okay.
is borderline high, then it's okay.
Are you satisfied, all the panelists, are you satisfied with the data of the cardiovascular safety that vildagliptin has offered us? The VIVID trial and thereafter the meta-analysis on MACE. And are we satisfied with the cardiovascular safety data of vildagliptin compared to, let's assume, TCOS or even on linagliptin? So are we satisfied with the softer endpoints of echo and the LVEF and the ventricular size? That's what VIVID trial has shown us. Then, of course, you have meta-analysis or compilation, where, of course, the grade 1 evidence, and which has told us that vildagliptin is pretty safe. And as it was just remarked that we haven't found anything untoward during our practice with vildagliptin as far as the cardiovascular safety is concerned. So are you fine with whatever data we have on vildagliptin on cardiovascular safety, Rajendra?
Yes, definitely. So in fact, I found vildagliptin to be more useful. Means I would say it was a class effect. All the gliptins, virtually they have got a good cardiovascular safety, and specifically vildagliptin has got a better cardiovascular safety profile as per this meta-analysis and as per the research.
Let's shift from MACE-3, MACE-4 to heart failure. Are you fine with all gliptins?
Definitely. In fact, I've found in my own practice, when patients I do prescribe, I found the vildagliptin has got a better cardioseptic profile even in heart failure patients.
Okay. And other gliptins, do you have any reservations?
I would say I have found better results with this. That's all. Otherwise, in fact, all other gliptins also have got better cardioseptic profile. But this has got CETA and Vilda has got more studies on this. That's why we can say that.
Shabir, your take?
So I'll prefer Lina if this cardio safety is concerned, I would prefer be going with linagliptin.
Specifically from heart failure point of view, because you have Carmelina, you have TCOS, you have Vivid, and then you have saxagliptin trial, which said something else.
Yeah.
And again, with allogliptin, there was a question mark in examine. So, in fact, there is a red box warning in NYHA class 2 and above, 3 and 4. You resist giving saxagliptin and allogliptin. The rest of the gliptins would be fine. And if we are to actually follow those guidelines, it will be better for our patients purely from the heart failure, not only heart failure, hospitalization for heart failure. And secondly, I guess it's important that if you were to look at all the gliptins that are available and look at the MACE data, there is nothing to choose amongst any one of them. They're pretty safe, all of them.
All of us.
So, as very rightly said by Rajendra, there is nothing wrong with saxagliptin as with allogliptin with whatever else. So, old age, what is your choice, Rajendra? Old age? Would you still prefer? Okay, and let me put it this way. Do you prescribe an SGLT2 over and above metformin as the first option if a gentleman about 65 or a lady about 65 comes to you, or would you prefer a gliptin?
I would go by various factors like what is the patient's renal condition.
Excellent renal condition, 70 EGFR.
Okay. If they are overweight, DPP-4 inhibitors I would prefer. If they are normal weight or they are this one, I would prefer. If they are overweight, I would prefer SGLT2 better. But if they are not overweight, I would prefer DPP-4 inhibitors as a first line.
So, are you fine with the safety data of DPP-4 in old age?
Yeah, specifically when they are able to take care of other things like infection, when adequate hydration, if they have got no history of diabetic ketosis, then I would definitely prefer SGLT2. But if any of this factor is compromising, like a urinary tract infection, this one dehydration chances, or other, if I find that they are not able to take care of them well, then I would prefer DPP-4 better.
You mentioned infection. Mitesh, in COVID, if you were to, and if you had to, on a cold patient, if you had to prefer an OHA, what would be your choice? DPP-4, SGLT2, metformin, pioglitazone, glenides, sulfonylureas, what would you give? Mitesh?
Yes, sir.
Yeah.
This
How have you treated your COVID subsets? What is your preference of OHA? And if you could enlighten us.
Yes, sir. I got your question. So, first of all, I would like to clarify that the COVID patients, that depends where you are treating,
Yes.
whether at home, whether at hospital, or whether it is at ICU settings.
Absolutely.
So that depends upon where the patient is. But anywhere, first and foremost thing, if somebody who is already diabetic and already on some OHS and on stable dose, at home, without any complication, even if it is SGLT2 receptor inhibitor, or even if it is DPP-4 inhibitor, or even if it is sulfonylurea, and if they are not at risk of hypoglycemia, then I would like to continue the same. Second
thing, is there
thing,
anything to choose amongst?
So I'm coming to that. So if somebody who is having first time detected hyperglycemia, and then my first choice is obviously DPP-4 inhibitor, not even metformin. The reason for not choosing other OHs like sulfonylureas, there is big risk for hypoglycemia, particularly in COVID patients, those who are sick, they are not taking orally. So sulfonylurea is out of question. Second option is metformin. Metformin has an different issues like drug-to-drug interaction and metabolic acidosis, lactic acidosis, and so. And there are some many a times GI tolerability is also an issue with spot-acting, immediate release-acting metformin. So metformin is also is not a good option also. SGLT2 receptor inhibitors, again, they are not good option to start with in sick patients, that everyone here are agree with me. And glitazone, again, pioglitazone, no doubt it is a good choice to start, but there are certain issues like hepatotoxicity and so. So rather than using pioglitazone, we have safe option, gliptin with us. So it is wise to start with gliptin, and it is again wise because if we have to give basal insulin or bolus insulin at that moment of time as well, you can start safely these gliptins.
Yeah,
So
Shabir.
these gliptins amongst all available therapies for management of diabetes in COVID patients.
Well said.
Mitesh, one question. Basically, when you said a sick patient and COVID, so when they are all on they are on OHA, and when they are also put on steroids. In fact, if we have seen this time, there was a lot of overuse of steroids in COVID patients. There, what would you do?
Sir, that depends upon the level of hyperglycemia. It is not the always we start with DPP-4 inhibitor and straight away. Obviously, insulin is the option, but if you choose oral hypoglycemic agent, then DPP-4 inhibitor scores over other OH.
Definitely, it scores over this. Yeah.
Insulin is the obviously is an option that you have to monitor the hyperglycemia. You have to monitor every 4 hourly, if required, every 2 hourly, and start an infusion. And then after the adjusting the dose of insulin, and you add on DPP-4 inhibitor. That depends from patient to patient.
Okay.
This is music to ears. Well said. What is the level, Shabir, you are comfortable with a patient, whether it is stress, hyperglycemia, already pre-existing diabetes? What levels do you keep the patient? What are you comfortable with of glucose levels in ICU, and how do you manage hot patients in ICU of diabetes?
So I would prefer an IV insulin for those who are in ICU, because performing 6 hourly RBS and giving them every 6 hourly is the worst thing what we can give to the patient. Because when we are talking of an era where we are talking of glycemic variability, and giving 6 hourly to a patient is just rubbish according to me. So I will start just IV, and every 2 hourly I will manage it with a very short acting insulin available in the market. We can precisely use and keep the targets, right? So I would like to keep as low as possible, maybe around 150 would be my target to keep the insulin.
What's the
Even,
level, what's the
what
number
Mitesh
that
said,
you are comfortable with?
150 milligrams, sir.
Yeah, okay.
Around 150 I'll keep, right? And what Nitesh said, sir, I have a different sort of practice I've done in COVID, because I don't have very good data, and maybe after a year or so we'll come up with some new guidelines that what we should use in COVID. But what I've seen and what everybody agrees with me, I think you will agree with me, sir, that it is an inflammatory condition. There is so much inflammation everywhere in the body, and it is a pro-inflammatory condition which has become, those who are non-diabetic has become diabetic.
Yeah.
So, there is some sort of inflammation going on in pancreas as well. And giving some drugs like even sulfonylurea and even DPP-4 inhibitor. Sulfonylurea even pressurizes your pancreas, as well as DPP-4 have a side effect of pancreatitis itself. So it's preferably I've used insulin in every other patient, giving a benefit that I don't know what's going wrong with the pancreas, and how much damage my steroid is causing to the pancreas, or diabetes, or the corona itself is causing damage to my pancreas. So it's better to give as far as possible insulin, so that I can give something better to my patient. That's what I've done in this last 13 months. I'm not aware whether I've done it right or wrong, or whether I should have used OHA in that patient. But maybe after a year or so, we'll get some good data related to this.
Brilliant, Shabir. Very well said, because that's what we have been now, since we are catching our breath and resting, because now we feel that the COVID is on the ebb. And now you're seeing it's almost like the GDM patients turning full-blown diabetics, 35–40% of them becoming diabetics who were not diabetics and who thought were having only GDM and needed lifelong therapy. And that's exactly what is happening as a sort of inflammatory condition affecting either the liver or the pancreas, more commonly the pancreas. Because if you now, I'm just in the midst of about 11 patients, not more, where I get a C-peptide level down, those who are not diabetics and became diabetics, needing, and how do we know they became full-blown diabetics? The levels are astounding, 300, 400. And after 15 days, 20 days of discharge, when they did not need any medication, and I'm not only talking about people who were given steroids, there were people who just
So without steroid.
Yes. So if you got the C-peptide levels down, you could possibly, theoretically, find out if we are harming or COVID had harmed pancreas for good. And if we knew the C-peptide, because presuming they were non-diabetics before the illness struck, that means they had a robust C-peptide and they had no need for anything else, intervention point of view, to manage the glycemia. And if we got the C-peptide levels done, and as you very rightly put, I don't know why, but of course we have enough and more evidence and papers on DPP-4 as Mitesh rightly put. Everything points in favor of giving DPP-4 to cold patients, and it has been supposed to be a very, very effective drug. But as you very rightly put, anything that needles pancreas, I think we stay far away from it because we don't know. And of course, right now, we are all in a very uncharted territory. We don't know what we are doing. We are learning on, is it as if we are, as in Gujarati, which is such a rubbish thing to say as a medical practitioner, but the heart saaf kari hai, which is terrible. Hands-on, you are treating patients, learning hands-on, which is likely to happen in any new ailment. And as you very rightly put, insulin, maybe basal insulin, and a single shot. And the guidelines may vary. What would be the ideal glucose level, and how would you manage a patient who has had COVID, and what to give, and how to save the pancreas, and how to save the beta cells from getting destroyed by inflammation. Brilliantly put, Shabir. Very well done.
Thank you. Thanks.
In fact, Dr. Mankar sir, actually, this time, because this was a second wave, in fact, everybody, apart from the physicians and intensivists, started treating COVID. And not only that, they started treating earlier with steroids. Even in the first week, that is what which caused this all havoc.
Yeah, fact, I'm sure.
And late starting of the insulin.
But Rajendra, we, like, for example, all those individuals who have autoimmune diseases, all right? An SLE, for example, or Wagner's, or even a simple rheumatoid arthritis, which needed intervention with steroids, they never turned diabetics full-blown.
Exactly.
Their glucose levels still remain. There is something that happens with this illness, which is tweaking the balance, and it just offsets the balance. And it actually must be happening either at the cellular level in liver, where the hepatic glucose output or a neoglucogenesis or glycogenolysis is a problem, or the renal absorption is compromised, or we are dealing with direct effect on the beta cells in pancreas. It's a very, very, and I don't know, all of us, if we pool the data of patients who became newly diagnosed diabetics post-COVID, there would be a huge number.
Yeah, I agree with you, sir.
Girish, you have any questions to summarize or say anything? We had enough, more than enough.
Thank you very much, sir. Actually, I was just listening very carefully to you because the discussion was very really. Sir, as rightly said, you initially that for OD dosage, I will try to provide you all the papers what we do have in very short time. And then I do respect your opinion regarding OD dosages, and definitely I would try to provide all the documents what we do have with us, sir.
You know, Shabir mentioned time in range, All right.
जी sir. जी sir.
Twice a day gave me a lot of security.
Okay sir.
And I could almost keep, even at 4 a.m., a patient at 148 or 156. Not with OD days, which I give it at 8 a.m. before the chap goes to the office. Then I'm worried, what is he? And if we have the data, post dinner and 2 a.m., 3 a.m., we'll be in for a surprise compared to BID dosage. So, as I keep saying, don't try and fix things which are not broken.
Okay sir.
There was no need to do all this. You had to educate clinicians that what they were doing was wrong.
Okay sir.
Giving vildagliptin OD just to be kind to the patient, to be in their good books at the cost of ruining their glucose levels, what the way they practiced, and they ruined a good thing. So twice a day is twice a day. You can't give 25 milligram twice or whatever, unless you are renally compromised or you have some other reason on sulfonylurea along with the DPP4 causing hypoglycemia. Otherwise, there's no need to do all that. Just keep
Yes,
it
sir,
simple.
yes. Very true, sir. Very true, sir. But sir,
Sir, I'm worried about that. If some people will give this OD dosage in half dose, then they become the tablet, and what will happen with that patient? You know, the sustained release mechanism will be hampered in that. I don't know how they are going to prescribe this.
So, Shabir, that is my question. If you have something that takes care, even if not 24 hours, 18, 20 hours, and it is OD, and if it is really increasing, and you remember, Girish,
yes, sir.
there are not very many persons with diabetes who need just a tablet. Okay.
Okay, sir.
They are on. So if you are talking about compliance, then get real. They will be on statins at night. All right. They will be on some rubbish methyl cobalt or whatever. And then there will be on some antihypertensive, which is to be taken twice a day. And they will be on sulfonylurea, which is to be given once a day, which is given twice a day, like glimepiride. So we do all sorts of rubbish.
Yes, sir. Yes,
Right?
sir. Agree,
So,
sir. Agree, sir.
trying to make vildagliptin acceptable, which is great. Cost is a huge benefit, but OD, you will have to come up with some robust data to tell people that we are as good as BD dosage as far as glycemic variability and time in range.
Yes. Sir, just to share one thing, sir, why we have come up with OD dosage 100 milligram, because as per this study, what we have done, more than 63% prescription for 50 milligram were also even for OD dosages.
So
that
that's
was the
exactly
only
my
reason.
point. You are trying to further unscientific practice. Just because some idiot is writing OD, so you said OD, so they're writing OD, so let's give 100 and make more beneficial to the patient. At least they receive 100 milligram. And since it is glucose dependent mechanism of action and it doesn't cause hypoglycemia, so 100 milligram is, don't do wrong things.
Okay, sir. Okay, sir. I understood, sir. And
All
I do
right.
respect your opinion also, sir.
Yeah. All right, Shabir, Rajendra, Mitesh, thank you very much.
Thank you very much, sir.
Thank
Yeah,
you
thank
very
you.
much.
So,
Have a
Good
great
night.
night. Okay.
Yeah, good night, sir. Good night.
Good night.
Okay, thank you.
Good night. Good night.
Thank you very much, sir. Thank you for giving your valuable time and helping us to establish this entire panel discussion, sir.
Sure. Thank you.
Thank you very much, sir.
Okay. Good
Thank you,
night.
Rajesh, sir. Good night,
Thank
sir.
you. Good night. Panel discussion and promotion.
Ji, sir.